Good morning, all. CVI now is becoming a topic of interest. It is an emerging cause of blindness. Actually, to say we are moving from ocular blindness to brain blindness in children. Maybe because the survival rate of, because of the better neonatal care, the survival rate of children with prematurity, metabolic problems, and other severe problems is becoming better. So finally, we are ending up with children having CVI. In CVI, most important thing is even if the child has 6/6 vision, the brain is not allowing the child to see what the child is actually seeing. So if we fail to understand this at the early stage, the child will become like it'll be like rest of the development will be delayed. So finally, the child will be emotionally, socially crippled. So it is important to understand what is happening to the child, when and where is the problem. At least to make the child, we can do the start the investigation, intervention early. The quality of life of the child can become better. To understand this, little bit of like how our brain works. Our 90% of information to the brain is through visual stimuli. And it is so intricate. 50% of the visual processing, brain works on visual processing. So with all this intact, we will be able to capture a visual scene within 1/10 of a second. So to have a closer look, it is a complex mechanism which involves eye, brain, and the pathways in between. It is not only the ability of us to see 6/6, it is also to understand, respond, and store whatever we are seeing. With everything intact, I think you all can read it. Even though the words are jumbled, we are able to read this because whatever visual memory is stored in our brain. In cortical visual impairment, what happens is there is a damage or malfunctioning of the retrochiasmatic visual pathway in the absence of damage to the anterior visual pathway or any major ocular disease. But sometimes there can be combination of ocular problem along with CVI. So the child can have good, mild, or severe visual loss. It is important to understand these two pathways. It is dorsal and ventral pathway. Dorsal pathway is the where pathway. It tells us where the object is, to locate and reach out for the object, and for simultaneous perception of the object. What is simultaneous perception is, in a given time, 2 or 3 visual stimuli are there. A person with intact dorsal pathway will be able to identify the single letter or multiple letters also. For example, if you're reading a Snellen chart, if you're asked to read the third letter, you will be able to read it easily if your dorsal system is intact. If there is something wrong with your dorsal system, you will not be able to read in a Snellen chart. But the same line, if you're given in a single optotype, you will be able to read it. This is called crowding phenomena. So there should not be any visual load. In case of visual load, the child will not be able to perceive the image. And they also have difficulty in climbing stairs. They can see, they can write well, but they cannot copy from board because of the crowding problem. Next is the ventral pathway. It is our temporal lobe. It is the storage place for us. It stores all the visual memories. If something goes wrong here, the child will not be able to discriminate whether it's notebook or apple, A or B. And they also will have problem in recognizing the face and the expressions. So we all know occipital lobe helps us to see better. with a good color contrast and form vision with a good field. Temporal lobe, even though it's a small portion is involved, it helps us in seeing the moving object. There is sometimes what happens, even if the occipital lobe is affected, the child cannot see the static objects, but temporal lobe is intact, so she'll be able to see the moving object. If we recognize this early, it will be easy to train the child using that small portion of the vision. So the presentation will be variable, depends on the timing, area, degree, and duration of the insult to the brain. Coming to the causes, if it's early onset, usually it is associated with developmental anomalies, maybe because of defective closure, clefting, or migrational abnormalities. In case of preterm infants, it is very common to see periventricular leukomalacia and intraventricular hemorrhages, which in turn result in CVI with varying grades of cerebral palsies. In late onset, it can be infection, tumor, or circulatory arrest, or near drowning. Like multiple causes can lead to cerebral vascular impairment, cerebral visual impairment. Based on the areas of damage, and we have seen already, if particular part of the brain is affected, and this shows how our visual acuity or the visual system will be affected. If it is only focal, then only 1 or 2 areas will be affected. Like some children can have 6/6 vision, only inferior field defect they can have. But if it is diffuse, there will be multiple problems. And before dealing with the children, we have to understand we are not only dealing with the visual impairment alone. They can have motor disability, intellectual and cognitive impairment, and difficulty with coordination. So it needs a multidisciplinary approach to handle these children. And they also can have other associated systemic problems. They can have epilepsy. They may be on drugs. So what to expect from an individual child will vary, depending on what kind of illness they are having. Apart from the routine ophthalmic evaluation, they may need some special investigation. But even for the routine evaluation, what the instruments which we use for CVI children will be different for the different compared to the normal children. Coming to the visual acuity, even visual acuity can be 6/6, but you have to differentiate between ocular visual impairment and cerebral visual impairment. In ocular visual impairment, the visual acuity will be same in whichever environment you are checking. But here, if the child is put into an unfamiliar environment, the visual acuity will vary. So to get the real vision, the child has to be familiarized with your clinic, same place, same person, for few consecutive visits to understand what the visual acuity is. And already we discussed about the crowding phenomena, and they see better in a plain background than a complex background. Their color vision will be better because color perception needs only few neurons and it has a large diffuse representation. And they have strong preference for red and yellow, which later it will be useful for us to give therapy for them. And many children can have field effect depending on which area of the brain is affected. Conventional methods may not help us. We cannot do Jerem screen or anything for them. We may use confrontation method with the familiar objects like a toys or light we can use to assess the field, or obstacle walking method. So you put some toys or something in the floor, make them walk, then they stumble on the object, then you understand they have inferior field effect. They have light preference to gaze at the light. So these are the few things a few specific problems which the CVI children can have. It is simultagnosia, which perceiving more difficulty in perceiving more than one object at a time. Prospagnosia, it is difficulty to recognize the familiar objects, familiar face. Parents many times will complain. The child can recognize me at home, but when I go to school, he's not able to recognize me in the crowd. So this is the assessment form which we use. This also help us to identify, locate the where the problem is, and also in due course to prognostify and see the progression also will be helpful if we have any methodical way of assessment. See, these are the few instruments which we use for measuring visual acuity in children. This is the Leah paddle, which uses the contrast method. And this is the Heidi, which is for contrast sensitivity. This is a grating method for visual acuity. Color vision, Ishihara's many times may not help because that's also like a crowding phenomena for the child. So D15 can be used for assessing color vision, or the toys can be used to assess the gross color vision. And this is the mailbox test, Leah mailbox test. This is to check the orientation and hand-eye coordination to eliminate optic ataxia, and to recognize acuity and the color and the shapes, we use Leah puzzles. So like that, many small instruments are there, or we can make our own toys and things with the help of our own carpenters to simplify, to understand their visual status. It is important to understand the range of the impairment to start the therapy. When to do the investigation, it's always a question mark, but baseline MRI is needed for most of the children, whether even if they have a neurological problem, or if visual acuity is not correlating with your ocular diseases, or if the child is 6'6", but with higher functions, or they have problem in higher function. In all these situations, the MRI needs to be done, but you need not wait for the investigation to come. You can start your therapy as early as possible, because many times these children may need MRI under general anesthesia to get the fitness. It may like take long time. So you need not wait for till then. So VEP may give a clue, does not give a prognostication, but sometimes the child will not fix and follow. You may think child is blind, but even if some neurons are active, VEP will be like will give us some clue, so that we can start on therapy for these children. It may or may not help them. So coming to treatment as such, to begin with, whatever correction the child is accepting, we have to give. There is a misnomer, the child cannot wear glasses. It is difficult for children with CP or special needs, cannot wear glasses, but at least with support, when the parents are carrying the child, or when they are involved in the activities, we have to make the children wear, because it does not only improves the vision, it also improves the color, contrast, and everything. It is important to assess accommodation, because many of these children can have accommodative problem. This child is a CP child, like she was not fixing and following. When she came to us, we could diagnose that she has accommodative problem. When we gave her +2 glasses, she's immediately able to grab a toy. So this like very simple way we can improve the visual acuity. We can address the problem also. This is a second child, 9-year-old child, who came to us with mother complaining of unable to, the child had 6'6" vision. Repeatedly, mother was saying, my child has problem in writing 4-line notebook, has a problem with walking, and he is dropping objects, difficulty in unfamiliar places.
On stairs
You
and
can
bumping
see
into objects while walking.
he's just walking over the object. This is called like obstacle walking method, where we assess the inferior field. Child is not even looking down. So he has problem in inferior field. So here we give some like colorful things to attract the children to look down, like lighted shoes. And here is the small stroller with the lighting. So then the child tend to look down. So this way we train them to improve their field of vision. So mother told child has problem in writing in a 4-line notebook. So this is the writing guide. You can see rest of the places are hidden, only where the child is supposed to see. It can be used for reading or writing. So this way child will be able to see better or write better. Another thing is making the child go close to the TV. Many times parents complain will be child is going close to the TV because the child want to concentrate on only the particular object of interest. So he want to eliminate the rest of the visual stimuli. So this child is going close to the pumpkin, then picking it up. So that way they develop that kind of mechanism to, it's called approach mechanism. So we also can utilize this for them to manage with a crowded place. Another child who's 6 years old, hydrocephalus with impaired hearing, underwent VP shunt. He had delayed milestones, seizures, and studying in special school. Always like wherever the mother takes him, they say he's blind. But mother says he walks around, but everybody says he's blind. So when we assess his visual acuity, right eye was very poor, left eye 6/48. Even though it was poor, we could identify only his superior temporal visual field was intact. Rest of the field is gone. So you can observe when she's towing the paddle, left eye, superotemporal field, when you keep the object, he is able to pick up. So we teach the mother and the class teacher how to utilize the field. Here, simple way is make the child sit down in the class. Instead of standing or sitting on a chair, make him sit down. The teacher has to stand static and teach him in the temporal field. Then he will be able to learn. Some children can have problem in traffic. That is because of our temporal lobe. They have some problem with the temporal lobe. So this particular case, mother's typical complaint was child is seeing the weather forecast. A child is seeing a weather forecast, not cartoons. So it is so suspicious. What is it? Child is seeing weather forecast and not cartoon, because cartoon there is a moving object. So he is not able to be attentive. In weather forecast, you can imagine our weathercast people, like they are static. Maybe only they'll be moving the mouth to address, like a news reader. So then we get the clue. Then the teacher also should, like in his class, it was like a not a routine class where he was. That school teaches him like interactive sections. They move around, play around. So he was lost in the class. So we told them to change the school, and we spoke to the teacher the importance of static teaching for him. Then his academics, we saw a much improvement in his academics. Some children may have trouble seeing the facial expression. From early age, we have to start teaching them what is smile, sad, and anger. We have special cards for this. This child is a CP child and had a seizure disorder, came to us at the age of 6 months, not able to fix and follow, not recognize the mother's face, no motility, started vision therapy at the age of 6 months. And up to 2019, we had follow-up with her. It took almost 10 to 12 years to make her walk. And now she's able to see, contrast is better, she's able to better socialize. So it takes a very, very long time. And many children may not be successful up to this stage, this child also. But mother was also very patient. And continuity of therapy is very, very important. Simultaneously, they have to go for occupational therapy also. In the class and at home, using contrast is very, very important. Using thick pencils and with thicker lines, notebooks, and keeping the food in a contrast plate, black plate with the white rice, and using colored spoons. And even in the school or at home, very important to make the contrast in the floor also, and good lighting, and giving them strollers. See, what we expect is a child to walk at 9 months, a normal child, 9 to 12 months. We also expect these children to walk at 9 to 12 months. So we have to support them. Maybe just a simple stroller we can give them, so that many don't prefer their children to have the sticks because they will be branded as blind. So we can use the simple stroller to help them to walk. So we have to have adequate lighting at home and school, wherever they are. So early identification, intervention, and rehabilitation will make these children better. Thank you.